Hello and welcome to today's webinar, How Shockwave Therapy Can Change Your Practice. This webinar is presented by Zimmer MedizinSystems. I'm Regina West and I'll be moderating the webinar today. At any point during this presentation and Q&A, you may submit questions by typing them in the Questions tab of your webinar control panel. Following the presentation, we will cover those questions live. And if there's not enough time to get to all of the questions, answers to your questions will be emailed to you. Paul Cummings, a webinar panelist, will briefly contribute some additional information following today's presentation. And now I'd like to introduce the speaker for today's webinar. We have Dr. Richard A. Schilling standing by. Let's bring him on camera now. Dr. Schilling, would you please join us? Hi, Dr. Schilling. I'd like to give a little bit of background information on Dr. Schilling. I'm going to do an abbreviated version of this slide. Richard Schilling, DPM of ABC Podiatry, is an esteemed podiatric physician with 19 years of experience. He's licensed in Ohio and is board certified in foot surgery. Dr. Schilling graduated from Ohio College of Podiatric Medicine in 2002 with a doctorate in podiatric medicine. He completed a residency at DePaul Hospital in St. Louis, Missouri, as well as a fellowship training in reconstructive foot and ankle surgery at the Wheel Foot and Ankle Institute in Illinois. Through his education and years of experience, Dr. Schilling has developed specializations in diabetic foot care, sports medicine, reconstructive foot and ankle surgery, and wound care. And if you're just joining us, I've just introduced Richard Schilling, DPM, who will be speaking today on how shockwave therapy can change your practice. Welcome again, everyone. And Dr. Schilling, one more time, thank you so much for joining us. Excited to see your presentation. Okay, I'm going to hand off the webinar to you, and we should be able to see your screen in just a moment.
Okay.
Okay, I see your presentation there.
Okay.
And as soon as you're ready, you can take it away.
All right. Well, thank you, Regina. I really appreciate that introduction. And I just wanted to thank Zimmer MedizinSystems. I really thought long and hard about this purchase for my practice, radial shockwave machine. And there's a lot of different companies to choose from. I think forming partnerships makes you more successful. I had talked a long time with Paul Cummings about this technology and how it could help my practice. And it was very helpful in the implementation into my practice to have a partner like Paul to provide brochures, marketing material, things for my website. And it's become a real game changer for my practice. I really wanted to start off with showing you guys how I project having this in my own practice by using a banner that Zimmer MedizinSystems provided for me. We have our logo on the banner, and we've got a good conversation starter for our patients. So some objectives for tonight. I want to introduce the concept of radial shockwave therapy and explain how it will benefit you and your practice. Your patients will benefit from the treatment, and you'll benefit from growing your practice, both with a new treatment option and hopefully a new revenue stream. If you look at the top picture here, this is the applicator that is attached to the machine. This one here on the top has a black cap. This is the standard cap, and that's what I use for most of my soft tissue treatments. However, down on the bottom, it shows a blue silicone cap here. And this is when I'm going around a bony prominence or a very sensitive area. I don't like using that too often because it blunts some of the force that I'm looking for, some of the power or the energy. So if I do have to use the silicone cap, I'll either use it at the beginning of a specific treatment or in the beginning of the treatment protocol, and I try to get rid of that cap as soon as possible. Oftentimes, within the first 30 seconds of the treatment, the patient can then tolerate the treatment without that cap. I think it's important to discuss some of the background. You might get asked these questions by your patient, or just good information for you to have. But what is shockwave? I think, we've all been around shockwave therapy for a long time. This has been about 40 years in the ether for podiatry, at least. So shockwave is referring, in this case, to an acoustic wave, and it's carrying this energy into musculoskeletal tissues. It promotes the regeneration and reparative processes of the soft tissues. This kinetic energy is created by an electromagnetic force. That's as opposed to the air compressor models that we'll discuss later today. And this is transmitted through the applicator to propagate energy into the tissue. For some background as well, extracorporeal shockwave therapy, or ESWT, or high energy systems, started in Germany in the early 80s, mostly in urology. A lot of these systems started off with different applications and have grown over time. I can recall when I started my residencies in the early 2000s, we were using a lot of shockwave at my hospital. We were using large machines. We were putting people under anesthesia for this, and it was a 30-minute procedure. I went from a program during my residency of doing a lot of shockwave to a fellowship where the fellowship director was the president of the International Shockwave Association. So we certainly got a lot of experience with shockwave in the early 2000s. At that time, that's about the time that the US FDA approved ESWT for the treatment of plantar fasciitis. What you're looking at here in the corner is I believe this is an oscillotron machine, and that's what I used mostly in my residency and my fellowship. We had great results, but there were a bunch of drawbacks. The main drawback was pain. It's a painful procedure to be done. It took over a half an hour just to do the treatment, which meant that you were stuck for 90-something minutes when you talk about anesthetizing through nerve block, using conscious sedation, and the scheduling for these things was a nightmare. The lucky thing for me during my fellowship is the Wild Foot and Ankle Institute had their own shockwave machine, and we had our own OR suite with a anesthesia department person on staff. So we had some advantages, but it still was very time consuming. And then you'd have to have the patient rest and take time off, sometimes immobilize their foot in order to have the treatment be effective. So moving forward through time, creating this newer orthopedic usage, we started off in about 1988 in Germany, using these on non-unions, and it was successful enough that other applications became popular, like lateral epicondylitis. But we've moved forward even more, and currently using these radial technology machines has allowed us to eliminate the nerve block, eliminate the anesthesia aspect of these. It is so much easier to incorporate this treatment into my practice because I can treat people sometimes on the first visit. There's no downtime for the patient. I think when you're trying to present your plan to the patient, it's important to explain all the options, whether it's their first visit with a new problem or an old patient that comes with a new problem. I try to be fair and equal about presenting the traditional approaches of rest, ice, compression, elevation, NSAIDs, injections, all those old thought processes of tamping down inflammation. And then I contrast that with some of the newer ideas of really using inflammation as a healing device or tool, creating acute responses from senescent or chronic tissue. What I also like about this treatment option, not only the high success rate, I think in my hands, the success rate's over 80%, but I would still stick with that 75 to 80. I'd rather promise low and deliver high. But what I like most about this is having the ability to do it same day. So I'll be speaking to the patient. Let's say it's a new patient, it's plantar fascial complaints. After the presentation of my options to the patient, if they're interested in this, I'll close out that visit. You get your E&M code, you certainly use that as a traditional visit. And then I'll say, we can start today, and then I'll have my staff bring the machine in. I think that this is great to capture their interest now, not have to schedule something that they may cancel or that you have to deal with putting on later in the week or the month. What are we doing with this radial shockwave therapy? How is it helping folks? It's creating this inflammatory response. We're creating angiogenic growth factors, neovascularization. This promotes tissue repair through increased blood supply. And I think that all makes sense to patients. They like hearing that their body is going to heal this from the inside. What I also like is that there's really nothing that they need to do. I don't want them resting. I don't want them icing. We ask them to go out and jam on this. That way they can improve their treatment by improving the blood flow to the area. I think also it's important that you explain to the patient that they're going to feel warmth. They're going to see maybe even some pink or almost red tissue, and not to be worried about that. Sometimes that first treatment does have a little bit of discomfort later that day. It's not anything painful, but it's something just to be aware of and explain to the patients. I like this slide because it's a nice visual representation of this propagation of energy into the surrounding tissue. I think the idea of radial pulse wave or shockwave therapy, it allows for recruitment of some of the tissues surrounding the point of maximal tenderness. And so you're having this energy transferred into the tissue, which helps heal it. I think this is a good time to mention that oftentimes, if we're dealing with something like plantar fasciitis, for example, and you're talking to the patient about point of maximal tenderness, what I'll often do is I'll take their plantar medial calcaneal tubercle, and I'll push, and that'll be sore. And then I'll kind of find how distal their pain is, how medial their pain is, how lateral, and how proximal, and then make marks on their foot so that when I'm using the device, I can kind of surround the tissue and incorporate some of that surrounding tissue for healing purposes. I would keep an eye on the counter on the machine. That way you're not spending all the time in the periphery, and that you do go back to that central area where they're having pain. I think also it's an important time to talk about pressure. I try to keep a consistent pressure with my applicator, but I definitely will read the room. And if the patient's having discomfort, back off a little bit. And if they're feeling okay, push forward a little bit. Your staff can do this for you and free up some time. I like to do all the first treatments myself, just to make sure that the patient's understanding what's happening, and I kind of speak to them as I'm going. But after that, if you train your staff to do this, they can do a pretty good job for you to free up your time. Electromagnetic drive system is what we're going to be speaking about tonight. The Zimmer MedizinSystem is an electromagnetic drive system. And what is important for you to understand about this is it makes your machine more durable and lasts longer. It has less maintenance than the air compressor systems. It also doesn't peak as high, and it is more comfortable, but while delivering more energy overall to the patient's treatment. We've spoken about how this works and what it is, but let's talk about the things we use it on. Clearly, plantar fasciitis would be the top number 1, number 2, and number 3 application for this. In my practice, I would say 75 to 80% of all treatments in my practice come from this. Achilles tendinitis is a really great treatment because there's just not a lot of good treatment for Achilles tendinitis besides stretching and offloading, staying off of it. You don't want to inject into that area. Retrocalcaneal bursitis, I've done some treatments on that. Had somebody who was having some pain post-operatively from removal of ostrigonum recently, and I was using my shockwave for that. And when we were doing the shockwave treatments, she mentioned that the scar from her removal of her ostrigonum had gotten softer, more supple, less tender. And so I think that that's a nice benefit as well. All tendonitis in my practice, this is a great treatment. But I've expanded as we've continued to use the machine and be comfortable. We've expanded to intermetatarsal neuroma, peripheral neuropathy, and wound care. Like we mentioned earlier, plantar fasciitis is an important treatment for you. I'm sure it's one of the number 1 soft tissue injury or pain that you see. So if you think about, if you could convert a few of these, maybe 1 a week, to get the shockwave therapy, that would be a very large improvement in your revenue stream for your office. And for 5-minute treatments, patients just do very well with this. I find that if you can say to them, simplify things, 5 minutes, 5 weeks in a row for $500. And that makes it a really easy sell. You can explain to them that it's just once a week. And I make them feel pretty special. I make sure that if I'm starting my patients at 9 a.m., I'll have them there at 8:45, or if I'm starting in the afternoon, I'll have them there 15 minutes before I start. That way, they're the only patient I'm treating. It's a one-on-one, and they feel like they're getting something kind of nice. No copay, no issue with any of that. Intermetatarsal neuroma. I tell you, I really don't like treating these the traditional route. Most people don't like the injections. I'm not really sure I like putting all that cortisone into that area. So I like that there's no injection with this treatment. I like that there's no stump, and I don't have to use local anesthesia. Again, for this the practical purpose, I'm using this plantarly. I'm making sure that I'm going between the metatarsal heads, and I'll use the black tip, not the silicone applicator. I do find with this, I don't do as much a medial and lateral motion as I would for maybe a plantar fasciitis, because the metatarsal heads are pretty sensitive and they're pretty close to the surface, especially in our older patients. So I try to steer away from those when I'm using the shockwave therapy for intermetatarsal neuroma. I've had excellent results with this. Paul had mentioned to me early on that this would be a nice adjunctive treatment for wound care. If you think about what we're trying to accomplish with the shockwave, we're trying to accomplish new blood flow and bringing growth factors to the area. And that's exactly what we need when we're talking about non-healing wounds. These wounds are stuck in a chronic phase, and this really brings it into a more acute phase. When I do these treatments, I actually don't charge currently because I don't have enough data and enough confidence that it's really improving the wound. I just figured it can't hurt. So I would debride, I would dress, and then I would use a quarter of the treatment. First, I don't want to overwhelm cells that are trying to grow. And second, I really want to give it just enough energy, not to be too long of a treatment. So I take it down, instead of about 3,200 pulses, which is a pretty standard plantar fascial treatment, I take it down to about 800 pulses. Interestingly enough, I had a gentleman, after I did a couple of these treatments and he had healed his non-healing diabetic ulcer, he messaged me about 3-4 weeks later and said, I don't know what you did to my foot, but I can feel my brake pedal again. And so a light bulb went off, and I said to Paul, does anybody use these for peripheral neuropathy? And he had said that a couple people had asked, but we hadn't really gotten much data. So we just don't have a lot of options for peripheral neuropathy. I've had some limited success with vitamin supplementation, but what is that trying to do? It's trying to improve blood flow through nitric oxide formation. It's trying to heal nerve, in a way, re-insulate the myelin layers. And, currently neuromodulators only mask symptoms. So I thought this guy had a pretty good result. Albeit anecdotal and almost accidental. So I proposed to some of the Zimmer MedizinSystems higher-ups that we do a study, and they have greenlit me on a pilot study on peripheral neuropathy. So I'll be hopefully publishing that data within the next couple of months. And if that pilot study goes well, we will probably look into a multi-center trial where we can really use this device to start treating our patients. And imagine if we could add a new indication. I mean, people pay so much for their treatment of peripheral neuropathy. I can't tell you how many patients come in my office telling me, oh, I saw this chiropractor and I got this $10,000 package. And I mean, it staggers me. And I continue to ask them, are you getting any better? And most of them tell me no, and they're still chugging along. So if we could get something that really works and use it to our advantage to help the patients and help our bottom line, it's a win-win. So we talked earlier about shifting from a anti-inflammatory modality into a pro-inflammatory healing modality. Well, you have to shift the way you think of your practice. We're all to the point where we're getting paid less for the same amount of work or more work, and adding cash treatments into your practice helps your bottom line and helps you stay independent. So for me, this is one of those things where I've really helped offset some of the losses from the decreased reimbursements by cash. what you don't think about too often is you think about, oh, I don't know, I don't think they'll pay for it. People are already paying out of pocket for these things. They're already paying for copays that are 40, 50, sometimes $100 a visit. And high deductibles are real. Last year, my personal deductible was $6,700. That means everything I did straight cash. I didn't have any help until I reached almost $7,000. So this is a treatment where I think that if you can have confidence in the data and see the results, it's an easy sell to patients. People always say, well, my patients won't pay. I practice in an area that doesn't. Well, that's just not correct. I think prejudging folks both on who will pay and who won't pay is a huge mistake. I would estimate that 1/4 of the ones that I've closed the deal on, I would have thought, no way would this person be able to afford or pay for this, and they do. People pay for what they want. Cigarettes are expensive, tattoos are expensive, those bags that they carry are expensive, $1,000 phones that people carry, manicures and pedicures, and especially to avoid surgery, people will pay. I think also if you're to the point where you're ready to get a surgical procedure, you're gonna have to take time off work. So I think this is a nice adjunct to your practice, but it's also good for the patients. I will say this, that in the beginning of my thought process with shockwave therapy, I would usually hold back discussion on shockwave until all else had failed. And then one day I was talking to a patient who had failed conservative care, and she said to me, I don't know why we didn't talk about this in the beginning. I would have skipped all that other stuff and gone straight to this. So for me, this is something I present on first visit now. I weigh both options for them. I make sure that there's lots of choices. This is not a pressure sale. This is the opposite. This is explaining things that you have available and seeing if they're interested. I don't want to hear I'm not a good salesperson. You are. All of the doctors that are watching this are selling your confidence. You're selling your plan. You're selling your education. I think that this is one of those things you just have to get over it. You have to get over the fact that you're above this or not able to do. I think that practice makes perfect. The more often you talk about it, the easier it is. And it's just a conversation. In the beginning, I was lapping my partner and associate as far as number of treatments. And recently, they both kind of caught up to me. And I asked them what was going on. And they said that they're starting to see so many people come back that were successful. They feel more comfortable making the suggestion of this treatment option. So basically, all you have to do is ask. You would be surprised at how often they'll say yes and how much of an improvement, not only in your treatment protocol and how people get better, but your bottom line. I think, again, one more thing is it sets you apart from other doctors in your area because you have new technology and the machine is slick. It looks good. It's a very attractive looking machine. And I think that oftentimes people are impressed. Just like maybe 10 or 15 years ago when digital x-ray first came out, people were pretty impressed by that. But I think certainly this is an impressive treatment option for folks and it works. So thanks for listening. I hope that this was valuable in both your revenue streams and your treatment protocols.
Thank you, Dr. Schilling. What a wonderful presentation. I'm just going to take back the screen here. Give me one moment. And, I was really stricken by the great feedback that you've had from some of your patients, notably the patient who said, I don't know what you did, but I can feel my break again. That's incredible, really. Thank you, Dr. Schilling, so much. We'll see you again in a few minutes for the Q&A section.
Thank you.
And now I'd like to bring in Paul Cummings, who would like to say a few words. Paul is Zimmer MedizinSystems specialist in nPulse Pro for podiatry and sports medicine. Paul, would you like to join us now?
Yes, good evening, everyone. Thank you, Regina. Thank you, Dr. Schilling. Appreciate it. I will be brief because I'm sure there are a lot of questions for Dr. Schilling. And a lot of what I'm going to talk about will just echo what he was just discussing. Regina, you have the next slide?
Yes. There you go.
The take-home message. You consider this that just one patient per month covers your payment and it still creates a profit. Any practice can do that. And Dr. Schilling said, my patients won't pay. They will. So just getting one patient per month is not your goal, but if you do, you're covering your cost, you're sleeping well, you're making a profit, and you're bringing on a technology to your practice that you can advertise and market, which inevitably will bring in more patients. Let's say you just say 30 patients per month with plantar fasciitis, Achilles tendinitis, neuromas, any of the conditions Dr. Schilling mentioned. If you treat just 10% of those patients, and keep in mind that means that 90% of the others say no to this treatment, which is pretty bad. As far as a close rate, or think of a restaurant, if 90% of people think your food is bad, that's not good. So, but we'll still use 10%. That's still 3 patients per month. So who are your 3 patients? One patient per month who doesn't want steroid injections for whatever reason. I'm afraid of needles. I'm holistic. One patient per month who just doesn't have the time for physical therapy. I work all day. I have 3 kids at home. I just can't do it. One patient per month who's exhausted all their options with other doctors and tried different things, and they don't want surgery. I'm sure most of you experience those exact patients. Average revenue nationwide is $500 per patient. So obviously those 3 patients per month would total $1,500 in new revenue. So again, it's easy for me to say, but it's a low cost, low risk modality to add to your practice. One more thing I want to mention, we just don't have a slide for, is that it's keeping up with your competition. I had a conversation with a doctor this morning about just this topic. Patients today are going on Google for everything, including finding doctors that offer new non-invasive treatment options. If there are other practices in your area offering and advertising these services on their websites and social media, and you don't, that puts you at a disadvantage. You know, you don't let other doctors or practices attract patients that should be coming to you. So I hate to use the expression keeping up with the Joneses, but again, if other practices in your area offer it, then you should too, just to show that you're staying current and that you're giving your patients a choice just like they are. Cost of the system, like I said, it's a very low cost in the grand scheme of things. Each system is $0 for 6 months. There's no payments at all. The NPulse 2.0 is $315 per month, and the NPulse Pro is $385 per month. So again, at $500 per patient, you can see it easily covers the cost. So it's treat one patient. It's kind of like having a free system. The nice thing about the financing option we use with this is systems can be paid off anytime after just 12 payments with no prepayment penalty. So you don't have to be locked into a long term if you don't want to. I'm going to hand it back to Regina and Dr. Schilling now, because I'm sure there are a lot of questions for him. Thank you very much.
Yes, okay, thank you, Paul. Thanks for that information. Let's get to the Q&A. Let's get back to Dr. Schilling. Would you join us again, Dr. Schilling?
Yes.
Okay.
Before we go to any questions, I would like to say that I liked the first 6 months of having no payments. It was less pressure. It allowed us to incorporate some of these. And I think what you'll find when you talk to your patients is you plant the seed. I would talk about it this visit, and then maybe 1 or 2 visits later, they'd say, you know, I'm ready to try that. So you'd be surprised at how many people ended up closing later. I do like the convenience of having that first visit availability, but not everyone's ready right away. And I noticed that the first 6 months allowed us to ramp up. And then we've had our system approximately 18 months. And I want to say we're over 50 treatments in. And that's a pretty low number, I would think. So we've effectively paid off our system in less than 18 months.
Wow. Okay, that's an important point. All right, let's get to the first question that's come in. Do you see success in treating retrocalcaneal bursitis with NPulse Pro?
I would say yes, but it's limited, and limited not in the success, but limited because I haven't seen a ton of these retrocalcaneal bursitis patients at this moment. I've only had the system for, I believe it was around, it can't be more than 14 months. So it's a pretty new modality in my practice. And before I had radial pulse wave, I wouldn't have really thought about treating retrocalcaneal bursitis in the operating room under the old ESWT. I would have thought that that was a very aggressive approach. I was always fearful in those areas of, especially with that high energy, of doing some sort of damage to the deep tissue and bone. So I would say in my limited use, I've had 1 patient specifically do very well with retrocalcaneal bursitis, but that is a great indication. And sort of in the same vein, I've had a lot of success with Achilles tendonitis.
Okay, are steroid injections used in combination with this treatment?
Never, never. Many reasons not to, but it really, if you think about what you're trying to do with your radio pulse wave, or excuse me, radio shockwave therapy, in my practice, we call it pulse wave therapy because it's a little more, it's less scary. So anyway, I've gotten used to the same pulse wave, but no, never, ever, ever combo. And the reason is it counteracts everything you're trying to do with your radio shockwave therapy. So having NSAIDs, having steroids, having injections at the same time is an absolute no-go. You don't even want them icing. You want them running, walking, being active. I will say the one thing I do in combination, and I hate to be salesy about this, is we do a combo of our medical grade orthotics. We give 25% off our medical grade orthotics with the purchase of the shockwave therapy package. And I think this encourages people both to, they like deals, but also what I like about it is I'm reinforcing my treatment by using the medical grade orthotic on top of the shockwave therapy.
Okay, what's the difference between focused and radial shockwave?
Great question. You know, focused is more focused, and its depth of penetration is really the key. So that focused energy, which is what the ESWT is really great for bone treatment, whether it's non-union, whether it's really non-union with the main difference. But also focused energy is more painful, so you need a lot more anesthesia, and then the cost is significantly higher, sometimes double the cost of radial. For soft tissue and for what we're trying to do in our shockwave, this is really what you need, because this is more of a propagating through the tissue, a radial motion of the energy rather than focused on that one particular point.
Okay, here's sort of a related question. Can you explain the differences clinically and related to outcomes between EPAT and radial shockwave, RSW?
Yeah, you know, I did ESWT for years, whether it was in my residency or with Dr. Weil. Even out of residency into my practice, for the first couple of years, we had a guy who would drive around with a Dornier machine, and he would charge patients $1,500. Well, total would be around $1,500 for this treatment. What I didn't like about that was the pain that it caused. Even with a PT block, a sural nerve block, I mean, I would do all these blocks and people would still be in pain. And what I also didn't like was it was very difficult to do a reapplication, a second or a third. First of all, the cost was prohibitive. And second, the time. What I like about the radio pulse wave or the shockwave therapy is that I can do a sixth one for free if I want. I tell patients, listen, I'm here for you. Let's do the package of five weeks in a row, 5 minutes treatment, $500, and then I'll be the good guy to say, hey, if you still need one more at the end of this, I'll be happy to put one in for you. So if you want to talk practical, you have this evaluation and management visit. So practice management here. You're talking about the treatment options. You're going over all the things that you can do for them. You close out that visit. You have 5 non-covered visits, and then you book them for 4 weeks for follow-up for another E&M visit so you can hear how they're doing. At that visit, if they're still having a little bit of pain left over, I'll throw in another treatment for them for nothing, and they'll be so happy and excited. I think, if you don't mind, Regina, I'm going to mention something I didn't mention in the presentation.
Sure.
I know it's a long time ago, but about 20 years ago in my residency, God, I can't believe this. I did a retrospective study, which was not a really high-grade study. I realized that we're into prospective double blinds, but at the time, this was the best I had. And I went through approximately 1,000 of the previous ESWT treatment at my hospital, and I called all these patients and I did a spreadsheet. And what I really found was the trend was they would get better at first, and then they have a dip of pain, and then they get better, then the pain, and they kept going up all the time. They never went back down, but they sometimes had these dips. So if you explain to the patient, you're going to have some ups and downs, but just keep it up. But I think the take home from the ESWT was that it took about a year for them to be fully resolved from their heel pain.
Okay, we have actually a few questions asking generally the same thing. Are any of the treatments covered by insurance? What information can you share in regard to shockwave therapy being covered by insurance, et cetera?
Sure.
Several of those.
I think the approach is it's not covered. Medicare, a long time ago, there was a pretty debunked paper that came out that said that shockwave therapy was not effective. And so Medicare kind of pulled the plug on all coverages. I don't know, probably it's been 10 or 15 years. And at that point, I don't think they're going to come back and recover these things. The reality is that for you and your practice, this is good news. What do you get for your stuff that's covered? You get 30% of what you bill? I mean, I did a toe amp today. I think I'll get probably less than $200 for that. It's not worth my hour and a half operating room, with the walking over there and changing the clothes and the getting in, the getting out. I can do this in 5 minutes.
Right.
And it's so satisfying for patients to get these treatments.
Okay.
Not covered.
Not covered. And there was, is it all, okay, so yeah, another question, basically same theme here. Is it all self-pay? And
Yes.
if so, how successful are you at convincing patients to pay out of pocket a fairly large amount of money?
Okay, so you just made a judgment. Fairly large is up to you. You're not their financial analyst. You don't know what fairly large is. People pay for what they want, whether they're getting nose jobs or they're getting, clothing or trips, or quality of life is important. And as we age, especially, people are looking to stay active. They don't want to take time off work. They don't want to stop going to the gym. They don't want to do the things that they don't want to do, like going to a physical therapist 2 times a week for 6 weeks in a row. They want to come in and out. And that's why I try to offer them these prime spots in my schedule where I can allow them to get in and out without waiting. They get in, their treatment's done, they leave, they're happy campers. They feel like, VIPs in a way, because they kind of come in, they don't have to sign in, they don't have to pay a copay. They already paid up front. So each visit, they're just there to get their treatment and leave.
Great. Okay. Is there any downtime? Can patients resume daily activities right away?
Not only is there no downtime, we encourage them to. Think about what we're trying to do. We're trying to promote good inflammation. We're trying to promote neovascularization and the blood flow to the area, which you're going to feel an erythematous change. You're going to see some color change to that treatment area, especially on lighter skinned folks. It's very clear and obvious when you're doing the treatment. You sort of see that area get a little bit more pink and a little bit more warm. And I would say it's encouraged to be active. And let's not forget the tenets of stretching and good shoe gear and allowing yourself to have some support and stability.
Okay. Do you need to block the area or use anesthesia?
No. Again, I think that would go against what we're trying to do. I don't want anything in the tissue that's going to change the way that the waves of energy go through. I want to make sure that these are set to specific frequencies. This is set specifically for soft tissue and not for soft tissue that's filled with fluid. So we certainly don't want to use local anesthetic, and you don't need to. The blue cap, the silicone cap, gives you a little blunting if you do need some of that. I've had a handful, not very many, but a couple patients say, that doesn't feel good. So I also mentioned earlier about consistent pressure with the applicator. If you have to back off a little bit, you can, but then try to go back through as the treatment progresses, both that day and then through the treatment protocol. That way they continue to get the most energy you can give them.
Okay. Do you use it for fractures or malunions?
I have had one experience so far in the last year or so that I've used it for a non-union, and it was very helpful. However, I think that if you're going to use it for a non-union or a fracture, let's make sure it's fairly close to the surface, like a sesamoid, for example. That's the perfect example. Sesamoid would be a great one. Now, I will tell you, this person was very sensitive, and we used the silicone cap for most of the treatment. I think that this, in conjunction with a bone stimulator, is a very effective treatment. But as far as fractures, fresh fractures, I don't have any experience with that. At my hospital, I don't take trauma call. I don't see a lot of fresh fractures. And I think that, again, that's something maybe for a more focused energy because it gets deeper. So I would say stick with the superficial things like maybe a sesamoid.
Okay, I hope you have a little more time to spend with us because
Sure.
these questions are really rolling in here. Let's get to, yes. Are there any contraindications?
I would say the only thing that I would make sure is that there's no tear. We all know that there's not much going to repair a tear. Whether it's a tendon tear or a ligamentous a tear, I would certainly want to make sure that we're not dealing with that. But I think, again, for plantar fasciitis, for Achilles tendonitis, those things are pretty straightforward. I think that, once you figure out what that PT tendon problem is, this is a great modality instead of having to be immobilized. I really like the idea of continuing to be active.
Okay, where do you apply the probe when treating neuropathy and the length of time for each location?
So as far as the probe goes, I haven't actually gone forward with my study. It's still in the protocol developing phase. But my plan would be to treat the plantar surface completely. And I was thinking about kind of evenly going through grids and doing kind of quadrants through and kind of mapping it out on only the plantar surface. I'm not ready to go forward yet with any kind of more proximal treatment. I realize that, we can talk tarsal tunnel and we can talk about common peroneal nerve and all these different areas. But I think for at least study purposes, the whole impetus for the study was that I was treating a puncture wound on the man's lateral midfoot, kind of around here. And it just so happened that I was using the surrounding tissue to recruit the neovascularization and growth factors. And that's when the guy said, I can feel my brake pedal again. And so that's what spurred on the idea of the neuropathy treatment. But I haven't gone too much further. We're still in the creating protocol point.
Okay, and what a remarkable difference that must have made for that patient's life, being able to drive properly. Okay, let's go back just for a moment to patient payments. Another question related to that. Can a patient use their HSA plan to pay for treatment?
Absolutely. Definitely. Most HSA plans have a credit card. And so I don't really care who's paying for it as long as it comes in. The reality here is we mentioned 5 treatments, 5 minutes, $500. You can do whatever you want with your machine. Lately, since our machine has been theoretically paid off, my partner's been toying with the idea of doing individual treatments. And it's not my preference, but he pays for the machine too. So he's been doing, he'll have a patient pay $100 a visit. I'm not a big fan because I think it's important that the patient complete the 5 treatments. But what he's telling me is that he has faith into these people or that they promise that they will. It's fine. I have one patient that she has a specific kind of job where she gets cash at these weekend gigs she does. And she said, look, I can really only afford $250 today, but in 2 weeks I get $250 more. So I said to her, we'll do 2 treatments for $250, and then before the 3rd treatment, you pay the second $250, and we'll complete the cycle. As far as closing the deal, it's not wrong to give them a sample treatment. I've had many patients, I would say about a tenth of them, 10% or so, where I'll say, all right, you're kind of a little bit wary. Let's get the machine out. We'll show you what's going on. We'll do a treatment. And then they end up saying, you know what, that felt great. That's really helping me. I'll buy the package.
Okay, do you have any treatment protocols and pricing that you can share for those protocols?
Zimmer MedizinSystems will give you some paperwork, and you can mess with that paperwork however you want, as far as putting your letterhead on, making sure that you like the numbers that they give. But they suggest that that your individual treatments are more like $150, but your package is $500 for 5. Now they'll say 4 to 5. I just like round numbers. I like saying 5, 5, 5. So for me, if they're better after 4, give them a 5th treatment. They've already paid $500. That doesn't bother me. And again, similarly, if they're not better after 5 and they want a 6th treatment, I'll do that for free. Some guys will charge, and that's okay. That's a personal preference. I would say to the patient, and I do tell them this up front, if they're not better after 6, they're not going to get better, and we're not going to continue this on just to continue it on.
Okay, what is the average success rate you see using Shockwave?
Again, in my practice, I think I'm closer to 85, almost 90%. I can think of the last 25 I've done and have really 2 that are, I would call failures. Now, interesting word, failure. Failure means that they're not happy. Did it work? It helped them, but it wasn't what they wanted. Both of those patients told me they were glad they tried it before they went to surgery, though. So I was actually pretty surprised by that. I would also tell you, let's go back to that retrospective study I did, and I would bet you there were some people in that study that they thought it was a failure the first 3 months in, but later on down the line, once that tissue got healed, they would tell you, you know what, I think it was more successful than I thought.
Okay, I'm guessing from some of your answers, this is going to be a no, but let's just get it straight from your mouth. Do you charge an office visit in addition to the treatment charge? Sounds like it's a
no. Number one, you're not gouging. You're not here. You're not doing evaluation and management. This is a treatment, and it's a treatment that doesn't have a code. So if you think about what a 99 code, 99213, for example, we used to base it on bullets. Now it's based on time mostly, or complexity. So I think that it's not appropriate, or it's not inappropriate to do that for your first visit. You're evaluating, you're managing, you're making a plan. So certainly you charge for that visit, close that out, and start the treatment. And after the treatment's complete, you say, I want to see you in 4 weeks to talk about your follow-up, and that's a charged visit. So imagine if you're the patient and you've just paid out of pocket for this treatment and you got to pay a copay. Not a very good look.
Okay, let's do one more question here.
Sure.
As a user of the device, have you had to replace or have repairs done on your equipment? And what is the life expectancy of the machine?
So if you go back to one of the slides I showed, I talked about the difference between electromagnetic versus air compressor. And these air compressor systems are more delicate and they require more maintenance. I have had my machine close to 18 months and we've had no issues, no problems, no repairs. Now, the machine I bought had 2 hand pieces, and asked me, do I ever use them at the same time? No. I felt like the second hand piece was just a backup. It was nice to have. It was ability to continue my treatment. If one of my hand pieces goes down, I can have that repaired and continue treatment and not lose revenue. So for me, I haven't had any of those troubles at this point.
Okay, thank you so much for your presentation earlier and for taking some time to answer some questions for us. Very, very interesting. Thanks a lot, Dr. Schilling.
Thank you.
And I just have one final screen here to share. If anyone would like more information about the nPulse Pro, please visit the Zimmer MedizinSystems website at www.zimmerusa.com and navigate to the nPulse Pro Radial Pulse Therapy section of the website. Zimmer MedizinSystems also has an assortment of waiting room materials available for you to browse on the shopping site at shop.zimmerusa.com. And if you'd like to speak with Dr. Schilling or Paul Cummings directly, please send an email to info@zimmerusa.com to be connected with them. And this concludes today's webinar. Thank you very much for attending. A recorded version of this webinar will be emailed to all attendees so that you may review any of this information at your leisure. Thank you and good night.